easy. You can use touch, you hold the hands, you pat them, you do it on the wall here. You can find a means of distracting them. Distraction therapy. What do you use? You want to distract the patient. What do you use? Huh? You can use music. You can use music. I have very interesting experience in the UK. For children office, it's a different level of thing. Different you have been in adult say for a long period of time. In our facility, 90% of the kids they have tracheostomy. You can see how seriously cerebral palsy, mental retardation, and you always organize play group for them. When you see a child that cannot lift hand, that cannot talk, that cannot eat, every day they take them to play group and play music for them. Immediately they start playing music with them, you see them. But you never know that they hear. They be smiling. They be dancing. So music is very, very important. What we do here is that we always ask the family, what type of music does he like? Playing music, let him listen. Some of them will tell you the one religious song that can carry them to the next level. So don't forget, it's very important. And these children, they do arts, they do drawing, all sort of things. So music therapy is very, very important. That's part of the seat. The physical therapy, yes. Potato stimulation, massage, pressure, vibration, tense, acupuncture, we know all this. And you don't have the physiotherapists here, physical therapy, reflexology, radiation therapy. I told you it's full for bone management, bone pain management, aromatherapy. Some of these things we are going to discuss in our years as complementary alternative medicine. We won't have time to get to that level. So pain assessment, psychosocial assessment. You want to assess the psychosocially. What is the meaning of pain to the patient and family? I said, when you enter a neighborhood, when you enter a neighborhood, or you are going on the corridor, and you are that person can be the but the Hausa must not talk. So that's the meaning of pain to them. And the thing is that if they make noise, the baby will die. That's what they believe. In 1987, I have a terrible experience I'll never forget in my life. They brought a woman in, she lied down, we are examining, and she brought the nylon bag nailed like this. What is inside the nylon bag? We open. It was the end of the baby. The other part is inside. And where she lives, the buses, or what's it called, the vehicle goes there once in 8 days on the market day. So the market day seemed 8 days to come, and she was in the house, the baby already decapitated, and have to wait till the next market day before they get the vehicle to come here. And she does not express any form of pain. That's not just for me. So the patient knowledge, preference, previous experience, economic impact of pain, and its treatment. Now that the medication has become possible now, I don't think everybody is going to be buying. I don't know how people are buying methadone. So we tell us about that work. So those are the things you are going to must know and find out. Now this is the assessment we are talking about for children. That is what we use. For what's it called, verbal rating, we have installed this that we get. And we want to take time here because we have to close it down. We want to take time to WHO and against it like that. But we might not treat WHO and against it like that. I believe everybody here knows what WHO and against it like that is. Everybody. So don't let us waste our time about WHO and against it like that. Not everybody. So let us just close. But okay, let me just talk about this. This is pain. You have pain. You have to group the pain into whether it's a mild pain or don't let me use this word, we're not getting very well. No, we still come to that. So this limitation of knowledge that I just learned. Lack of utility in neuropathic syndrome doesn't relate to its neuropathic pain. The emphasis is more on opioids. Absence of, you cannot go listen, does not take care of supporting care, behavioral. I'm looking for the slide. And I guess let's not just do that one separately. We'll take time to do that one. These are the common analgesics we are using in the FMC that time. Paracetamol, ibuprofen, diclofenac, codeine, tramadol. Do they still use pentazocine now? They still use pentazocine. Honestly, of all places I've been, nobody talk about it. We try to discourage it. We do a lot. I think that's the way we are working together. It is not on any record. I don't know. I don't know the country that they are using technology. Even in Africa. I was working with the United Nations Drug Committee. They wanted to know what is happening about it. And I also another one, IESP, want to fashion curriculum, free curriculum for Africa. And they were mentioning the medication. And I told them about pentazocine. If United Nations, I'm talking about the United Nations, then this, what's it called? IESP, the World Body. When I mentioned pentazocine, which is the commonly used here, they have never had the topic. And this is what, well, usually we find time for us to work on it. That's why I said pain is a very big one. You must not miss it. In a visceral pain, you know what called visceral pain? These are the internal pain, and you cannot see. These are the type of medication you can use. You can use opioid, Buscopan for cooling pain, sympathetic nerve block, and when somebody has cancer of the liver, they have terrible pain. And that's what we call liver capsular pain. Don't forget, patient with cancer of the liver. No matter how many medication you take, until you start steroids, not get any steroids. So that can be said, that is said. But we are doing this. Neuropathic pain, those are the causes: diabetes, cancer, HIV. The picture we showed you the other time, that man was really suffering from neuropathic pain. And I told you that chemotherapy also causes neuropathic pain. Amputation. How many of us have seen amputated patients? What did they complain to you? They have got the leg. Pardon me. Of course, it's not paracetamol or ibuprofen that you are going to use to treat that one. It's a neuropathic pain. Episusat, spinal injury. And when you see a patient, we are taking the issue. These are the things you notice in the patient that have neuropathic pain. These are the classical presentation: problem, shooting, stabbing, pains, needles, burning. And that will tell you that the treatment was cheap. You must be able to distinguish between neuropathic pain. So these are the neuropathic pain that you can see in cancer. Post-mastectomy, mononeuropathy, and post-odapotomy, because the one that have poor vision that you are training, you see cause that you have manipulated now here. Spinal nerve, spinal cord compression. We all know that. How many of us have seen spinal cord compression, spinal nerve compression? How many of us have seen? How many of us have seen? We just want to know whether to explain more. Who wants to know more? Nobody. Let us go on. Radiculopathy. We all know that. So these are the medications for neuropathic pain. The first line is tramadol. It's a norepinephrine serotonin reuptake inhibitor. That's the way it works. Incidentally, because of abuse of tramadol in Nigeria, those people who need it, they are not getting it. They are using it to get strength, to play ball, and do all those things. But it has some neuropathic component. I could remember the guys said you are going to ban it. So many centers don't have anti-neuropathic medication. Tramadol comes handy. In fact, we wrote a paper with people in Ghana that tramadol was, but they are going to go that paper for 2 years. The other one is tricyclic antidepressant, amitriptyline. All of us know that we use amitriptyline for pain. Anticonvulsant. By the time we are doing into analysis, I will show you all those things. 5% reeducate. Of course, we'll be using that one all this time. Capsaicin. You know what capsaicin is? So many medication we do. Capsaicin is like apathy. It's not very common here. It's like a cream. By the time you apply it on your skin, it burns you like pepper. But somehow, it goes back to relieve the pain. It's a cream. So neuropathic pain can also do radiotherapy, nerve block, epidural, TENS, acupuncture. People are using acupuncture, but I don't believe so much in it for cancer pain. This therapies, and when it heals, it's repeat on now. That effectiveness compared with Pigabali was compared, and they find out that Pigabali works beautifully in long-term treatment. So they are using that now. Non-pharmacological treatment, we have mentioned all these things: massage, music, extraction, humor, therapeutic touch. These are not medication. So that is non-pharmacological approach. But by and large, you must have behavioral assessment, total concept when you are assessing. You must share the information with the patient and carer, not like in India, where you don't inform them. You correct the reversibles. And you can put in specific treatment, palliative chemotherapy, palliative radiotherapy. This is beyond basic things. You say what to go to that. So in some way, understand the principle of pain control, where you bring your victim from, explain to the patient and the family how can you modify the disease and use pharmacological and non-pharmacological treatment. You assess the pain, you know what you are going to give, and you reassess. And do not forget, it's a multidisciplinary team care approach. Arrest like this. But the pain is more than this.
They are not laughing though. I think we can do better. We can do better. Thank you so much for that tutorial delivery. In fact, some of us do not know the words of what the guy gave to us. Some of these things, it took some of us in here. What the guy has summarized, and it's only a guy that can give this kind of lecture. Just few minutes. Because he has rightly started from the beginning the history of palliative care globally from James Sonda, the UK. Professor Amerima, when he came to Nigeria, to start hospice in Nigeria. But we missed the opportunity. Very painful. Before she went to Uganda, now they have hospice Africa, Uganda there. Now coming back to Nigeria, we have the first Department of Pain and Palliative Medicine in Nigeria, FMC Abeokuta. You do have a course for FMC Abeokuta. Even before you see it. Because this normally comes to some sort of argument. Anytime we go for conferences and we start to argue on who started palliative care first. But they know, and everybody knows. And it's in the book. Yes, of course. So we know that pain and palliative medicine started in FMC Abeokuta. So he has done justice to the topic, the principles. Palliative care, we have found life and death as normal process. And we neither hasten nor postpone death. Because you cannot even do that, because that belongs to God. But what we want to do is to how to integrate the psychosocial, the emotional and spiritual care, into patients' care, and also to offer them, the patients, the best pain management and supportive care that they need, so that they can live as actively as possible, and also to offer support system to the family. Like he said, palliative care is patient and family centered. We don't just look at the patient alone, but the family, because the family are suffering. Caregiver body, a lot that they are going through. Also, later he went to pain. Pain is a movie, like he said. If you want to know about pain, you can be using 1 month, 2 months, all the things he has rightly mentioned. Because it pains us when we see, even physicians, sometimes when we see some prescription, we laugh. You can imagine some doctors writing morphine 5 meals daily. So that shows that the skill is not there. That's why we need to train doctors, we need to train nurses, so that we can do the best for our patient. And also, we should know that pain, like I said, is not just physical. There's some that's talk about the concept of total pain concept. It's not just about physical. We have the psychosocial, the emotional, the spiritual. In fact, in Nigeria, Oga added sometimes that we have even the socioeconomic, the financial. Now because patient cannot pay for even morphine and some other things. So even the financial has to be looked into. So it has to be realistic. And you can't do it alone. And that's why palliative care is a teamwork. The other time when we started, we introduced ourselves as the team. Because you can't practice it alone. The clinical psychologists will have their input, the nutritionists, they will have their input, social worker, and their inputs. And that's why it has to be a teamwork. So Dr. Ogun has said it all, and I believe we have really gained a lot. So we are still going, in the afternoon, we are going to have a case scenarios. We get into groups, and we'll see cases, real life cases, some hypothetical cases. We have to go back to the lecture and see whether we really gained a lot or not. So from now, we move to our tea break. I'm sure some of us are not taking anything. And definitely, I'm sure the glucose is going down. And we don't want hypoglycemia, but it's not an emergency, so that we don't start resuscitating patients. So we'll go for a break now. So move. The tea break is already ready to serve us. Thereafter, we'll continue our program. Yeah, you still entertain questions later after the whole scenario. You still entertain. So you can pencil down or write down your questions, your clarifications in a paper so that we take them just once in a while. So tea break is ready. Thank you so much. which we can get into in details. So, accessibility to opioids, strong opioids, especially morphine and methadone, is one of the key essential things in palliative care, and that's why we cannot practice palliative care without the input of the pharmacists. They have been with us since the department has started, and they want to showcase the roles and the experience so far in the last decade. So I want to call on Pharmacist Lawal to come and give us his experience, the role of pharmacists in palliative care, FMC Abeokuta experience in the last decade. Thank you. A round of applause for Lawal. Yes, Farm Emmanuel is going to do the presentation. His Oga will be waiting. You will start, okay? So it's going to be both of them doing the presentation. So, okay, Olutoki Damola will be starting the presentation while Lawal will take over from her. Thank you.
Thank you very much, everyone. I believe a protocol has already been established, so I will start my boss to be coming on to share the experiences and then to take the questions and answers. My name is Emmanuel Ogun, and I'm here to talk about the roles of the pharmacy department, FMC, in the palliative, pain and palliative medicine over the past year. So this is I'll just give a brief background. I'll talk about the roles and the responsibilities of the hospital pharmacist, particularly as it regards palliative care. Then I'll show us some of the consumption patterns of some of the narcotics, particularly the oral. I'll focus on morphine and methadone over the years. Talk about the challenges, some of the challenges we have faced, and a few recommendations that we will conclude. Irrespective of the disease condition, we require drug at some point. And if those medications are not available, then what are we doing? Pain is a prominent feature of many disease conditions. And since the program started, we've had a lot of presentation on what pain is. And I think that's the crux of why we are all gathered here today, to learn about pain and then palliative medicine. So pain is very, very crucial in many disease conditions. It's one of the prominent things that we're going to see. In fact, it's been recommended as one of the vital signs that must be assessed in many disease condition managements and must be effectively managed, because if pain is not effectively managed, it can affect the total outcome of the care you're actually delivering. And pain management can be a bit challenging. We've been told there are several kinds of pain, not just the physical pain. You have the other types, the emotional, the psychological pain, the spiritual pain, and all of that. And all of that can make it a bit challenging. Then the severity of the pain too can make the process of managing pain a bit tricky. Now, the extent and severity of the pain determines the kind of analgesic agent you're going to be using. Now, we are talking about pain and palliative. Now, it's said now that palliative medicine is not only for terminally ill patients, but we know that many terminally ill patients, they experience a lot of pain. Particularly, the prognosis is already very bad. We already know that this patient is actually going to eventually die. Now, what can be done is just to make the patient comfortable and make the dying process as dignified as possible. And that is where pain and palliative come into play. So it is the role of the pharmacist. The role of the pharmacist generally on the palliative care team is to ensure access and affordability of most of the medicine that will be used. And as has been said, opioids are very crucial in pain and palliative medicine. So these are roles and responsibility of the hospital pharmacist generally. Now, embedded in some of these roles that I've highlighted here, there are a lot of activities that go on. We talk about facilitating access. There's a lot of things that goes into facilitating access. We talk about quantification. We talk about ensuring that or managing out of stock. We talk about storage. A lot of things that eventually facilitate access. Procurement, all of that, they are embedded in it. But the role of the pharmacist is to ensure that the drugs are available and available in good condition. They are effective and their quality as quality, affordable, and safe medications. Then, apart from providing or facilitating access to those medications, we also want to provide information, drug information services to both the other healthcare practitioners, the patients, their caregivers, and as many people as needed. Extemporaneous compounding, interdisciplinary collaboration, such as obtains here in pain and there's a lot of disease condition that a lot of people are beginning to understand that the management has to be holistic. A lot of people have to be involved in the care if you're going to achieve the goals of therapy ultimately. Then monitoring for adverse effects, and then to also have proper record keeping and documentation. This is particularly important when we're talking about opioids. We know that they are controlled medications. Regulations on them is very, very important. In fact, if proper record keeping and documentation is not done, it can impair access because the authorities can actually cut off the supply of such medications. Now, according to the American Society of Health System Pharmacists, some of the roles of a pharmacist in a palliative care team is very similar to the roles of a pharmacist in the hospital practice. Only that this time is more streamlined as it concerns the medication, the opioid medications. So we talk about access to the medication, you advocate for access to the medication, you address barriers to the access, you do the proper record keeping so that we can have the drugs, you do the adverse event management, the opioid stewardship. You want to ensure that the drugs, you have rational prescribing.